Hi, this is Sharon Gauthier from Senior Moments. Thank you for watching again. We have another episode that's more educational than anything for our senior population. AARP comes to you actually from the age of 50 on, I think. So you don't think you're a senior at the age of 50, but suddenly you start getting these postcards in to join AARP. So Nora Duncan is a friend of mine who is involved with AARP, and she was on our radio show when we had the radio show. So I had emailed her and asked her to come on, and she very nicely introduced me to these two fine gentlemen. So welcome.
Thank you very much.
The person to my left here is John Coates. And John, what is your role with AARP in Connecticut?
I'm an AARP volunteer involved in advocacy since I retired a few years ago.
Excellent. And what did you do before you retired?
I was in business leasing, finance, workout, bankruptcy work.
Mm-hmm. And then we also have Claudio, and I will not slaughter your last name, Claudio.
Gualtieri.
Gualtieri. And,
Good job.
And what is your role in AARP in Connecticut?
So I do a joint of advocacy and outreach, and I focus primarily on health, long-term care, and family caregiving issues. And John and I partner, he's my volunteer counterpart on some of the federal work we're doing around Medicare and healthcare right now.
So what do you look as, I know when Nora and I talked, which was probably about a year and a half ago, we talked a lot about caregivers in this state and the fact that there was like 500,000 caregivers in this state that are non-paid caregivers, and the impact that would have if in fact that left us caring for our elderly population, which is the population that we worry about the most right now. Is that still the case?
Yeah, and so let me put it into a little bit of context locally. Here in Connecticut, when we do, AARP does annual updates, and the last report that we have shows that family caregivers provided $5.9 billion of unpaid care to keep older loved ones safe at home, living independently. And just to kind of put it into context on a national level, Walmart is the biggest retail sales company in the United States.
Yep.
And the equivalent of their sales is roughly the equivalent of the billions of dollars nationally that family caregivers provide in unpaid care. So it's huge. It really is the backbone of our health and long-term care system.
So who's worried about that? And who should worry about that?
Well, I think you're bringing up two really important questions. One, who needs to worry about it? Well, for so long, we've focused aging policy around what the senior needs without concern for all the supportive functions, all the people around that senior that makes it possible for the senior to be healthy, age independently. So one, I think we all need to consider that at one point in our lives, we either will need a family caregiver to help us, or we will find ourselves in a role of providing care for a loved one. So I think it really is a universal issue that impacts almost every resident in the state.
And how do you think the state is addressing that or looking at that? Because I know we have an aging commission in the state. I know that some of the programs through CCCI, which is Connecticut Community Care, have expanded help for the Medicaid client, so the client that qualifies for Medicaid. I now have the ability for some of our clients that are Medicaid, that I'm conservator of, can have a 24-hour caregiver, which is a relatively new approach to funding. The other thing that I always get concerned about, and I've talked about this before to other people, is that I feel I probably have about 10 conserved people that are in convalescent homes who ended up there who had no family, and I was asked to be conservator person. And they don't need conservator finance in that instance. But as I visit some of these homes, it worries me that we're penny wise and pound foolish in so many ways, because I almost look at a good percent of the people that are in those homes are there because they don't have a home, not there because they need a skill. So Medicaid is paying for them to be there to have a home. And do you know what they pay a convalescent home to have a Medicaid patient in it? Do you have any idea what that amount is?
It's significant. I know a private pay room costs $160,000 a year.
So a Medicaid patient,
you probably have
I
a little
think,
bit of a discount, about 110, 120.
Yeah, it's about it's a little over $9,000 a month, I think, that they pay. So I also have the other part of our practice that deals with people who do have funds. So those people who have funds aren't Medicaid, and they pay to be in assisted living. I know multiple assisted livings in Connecticut that it would cost you anywhere from maybe $4,000, $4,200 a month on up, depending upon your needs, to live in an assisted living that some of these people could live in, and the state, if they paid for that, would be paying half that amount of money.
Penny wise and pound foolish. Those words came literally out of our press release reacting to the governor's budget
Is that
cuts
right?
in this area.
Yeah.
We have long fought for more cost-effective home and community-based alternatives to nursing home care.
Oh,
And so
absolutely.
one of the programs that's been a success, it was actually created as a money saver for Medicaid, is called the Connecticut Home Care Program for Elders.
Correct.
It takes care of seniors who have just a little bit more resources or assets than Medicaid eligibility. But if someone's going to live at home, you probably know this better
Yep.
than anyone. You
Right.
need some resources in case the roof goes, the furnace
Correct.
goes. There are costs with living at home that you need a little bit of safety net, some
Right.
assets to dip into.
Right.
A medical emergency is another example. And the governor's budget's actually proposing capping that program. So just as Connecticut's population is aging exponentially, new seniors in the future won't have access to this program that's proven to be 3 times more cost effective. We can serve an older individual at home at about 1/3 the cost of a nursing home care. So this is, again, one of those penny wise. It's an immediate savings, maybe because you're capping a program that you're paying on right now, but you're just prolonging a much
Correct.
bigger cost, a bigger liability in the future to our Medicaid expenditures.
And are they not listening to that? Is there a really large lobbying group for convalescent homes to continue the way they're doing? Because I get the sense that they're all really hurting out there. And, the whole structure of what a convalescent home is today should be so different than it's been in the past. In the past, it was basically the place you went to die. And the staff in there did nothing more than support your getting medications every day and no more than that. So in the last 10 or 15 years, we've now expanded that program within a convalescent home to now have, acute care, even though it's in a subacute setting. So now they're getting people coming in that are being discharged from the hospital a lot sooner. They're getting people coming in now needing the therapy that they maybe weren't giving many years ago. But what hasn't changed in most of the homes is the staffing pattern. So the staffing pattern, I believe, that needs to be in place are registered nurses. And historically, it's not registered nurses that are in a convalescent home, it's a licensed practical nurse. Those licensed practical nurses haven't been trained on that level to take care of an acute event, which is what created the crisis of readmissions. I believe that would be discharged from a hospital too soon, sent to a convalescent home, they'd send them back. Now convalescent homes, I think, are hanging on to people longer because they're fearful that if they send them back, that entity's not going to give them referrals. So I think it's a bit of a mess, and
It's
how...
also the nature of politics, unfortunately, where everyone is just trying to grapple with the enormity of a $1.6 billion budget deficit, and sometimes bad finances make for bad decisions.
Yeah.
I think this is one of those examples. I also think it's very hard when you're trying to tackle an immediate emergency to plan for the future. We really need to make sure policy looks prospectively, not at just the short term, but we can't keep budgeting from one emergency to one emergency. We've got to find a way to invest in the things that make sense long term and cut back where we can, but invest in the things that we need to invest in for the future.
What's some of the legislation this year that has been put in place that you think is a positive approach to some of our issues? Is there any? Because I don't see any this year.
It is one of those years that it seems like it's much more of a defensive posture. So some of the stuff is just making sure that trying to fight for the highest level of funding for things like family respite care, people who are taking care of a loved one with Alzheimer's or dementia, or home care funding, recognizing how important those services are to keeping people safe at home. There is some good work around trying to reform and create better efficiencies in the conservatorship and the adult guardianship system. There are some good proactive steps being taken to rebalance and figure out ways that we can enhance our flexibility in using Medicaid dollars so that we're delivering higher quality care both in hospital and acute settings and in long-term care settings. But it is one of those things where it doesn't feel like there's that big, bold call to action for seniors this year. It's much more, let's hang on to what we have because it's pretty bad out there.
So one of the things that came out federally that everyone jumped on was the Meals on Wheels program. And I really didn't look into the details of that, but was that a true effect that is going to impact Connecticut in terms of the Meals on Wheels program? Because I believe that that's more privately funded than it is federally funded.
Well, it's multiple layers of it because you do have the federal aspects. But for example, most people on the Connecticut Home Care Program get Meals on Wheels. They'll
Correct.
just access it through that state program. So there are different funding mechanisms for programs like Meals on Wheels, some being federal, some being through state programs that are now under attack at the state level. So it's a combination of both. And depending on, certainly there'll be a very real impact on people's ability to access senior nutrition if programs like the home care program and those home and community-based supports are cut in the state budget as well.
So what are the top 3 things that you think AARP in Connecticut tried to address this year with the legislature? Because this is a longer session, this session, right?
So one, we can't ignore the federal work. This year, a lot of our efforts have been around making sure that Medicare is strong, solvent, and remains with the guaranteed benefits that have been promised to seniors and to future seniors. So the federal healthcare work is a major priority. Second, I think at the state level, we're always mindful of utility costs. So
that's a
any
good point.
sort of regulations that are giveaways to certain utility companies or to certain energy producers that could raise the rates for seniors and for all consumers is a big concern. You might not always think of it as an aging in place type
Yeah, but it is if
initiative,
you're
but-
talking about
yeah,
fuel
but if you're
for your furnace, right?
Exactly, and some
Yeah.
have electric homes, and being able to access that stuff's important. And then I think third, the defensive work around home and community-based and respite care. But we're also looking proactively to start the conversation around the needs of working family caregivers. Last year, New York passed paid family medical leave. So they're doing at a state level what other states have started to do, like New Jersey and Rhode Island and California, and that is take a small payroll deduction from employees and allow them to access basically an insurance pool so that if they ever need to leave the workforce for a medical emergency or to care for an older loved one, they could tap into some form of wage replacement, a payment.
Is
so
that
they
being
could
looked
take
at
leave.
this year in
Yep,
Connecticut?
there's 2 bills that
And
have passed
what
out of the
committee
labor.
is that on?
The Labor Committee.
Labor Committee.
One is Senate Bill 1, and it's been given some high-profile stature because the Senate President mentioned it as one of the important issues he wants to work on. I think it's probably going to be a year where we keep building the momentum for it, but certainly it's been introduced, it's out of one committee, and there's also a House bill that's a companion that's pretty much the same language. So we're actually having a town hall meeting, a live town hall meeting with CPTV on April 6th to talk about, a deeper dive on this issue and how other states have tackled flexible workplace. Because 58% of family caregivers now, the reality is, are working. There is no more that person who stays home to care for
Right.
young children or older parents. It's working and doing that. So there's a real economic pressure on family caregivers when they have to step away from their career. And we just fundamentally believe at AARP that no one should have to choose between the family they love and the job they need.
Right.
So,
And that happens a lot, I think, whether it's a child that you're caring for or it's an elderly parent that you're caring for. I think people are compelled and pressured into thinking that if they lose too much work, they're going to end up losing their job, which is a reality for a lot, unfortunately. So, John, with your volunteer work, what is it that you see in the community that you could share with us that are concerns? Like, what do you hear from families and our elderly population in particular?
Well, with the initial efforts to repeal and replace Obamacare, a lot of information, a lot of it disturbing information, was impacting on individuals. I think the biggest the biggest negative was the amount of people who might not have been covered had the bill as proposed gone through. But the sum total of what we were talking about earlier, it does come down to money. And that bill was going to cost the average over 65 person or over 50-year-old person, depending, maybe upwards of $5,000 to $10,000 a year as it was being proposed. So AARP early and strongly came out against that bill as proposed, and there's still activity, and obviously the Obamacare is going to need some sort of restructuring. We just want it to be intelligent and to be taking into account the resources of our older population, and so money is always a top concern that you hear. There was also an element in there that we brought to some of our legislators' attention, which was an age tax. We are against any proposal to change. Right now, an elderly person can be charged up to 3 times more what a younger person is.
Right, for insurance.
For insurance. And the bill as proposed is going to be charging 5 times more. So you've got a limited population, or a limited income population, who are going to be asked to pay more of those limited resources for health care. And that's one of the additional reasons we came out strongly against that. Then proposed changes that were actually going to affect Medicare more than health care. Probably the biggest problem that we had is the discussion of price support or vouchers. Telling the people who had made a deal with the Johnson administration 50 years ago, where they were very comfortable in having their medical care paid for over 65, you're now going to be on your own. We're going to give you X amount of dollars, and you're going to go out there and shop for your health care. And it's obviously going to be a confusing landscape. So the voucher system is not something that the average person that we've talked to is in favor of, and certainly
Or would even understand.
Or would even understand. And I think with times being as complicated as they are, simplification is certainly not having to worry about one more thing is certainly of a concern to a lot of our elderly population. So these are prime things that we saw in going out to the community. And we brought these concerns forward. We met with our legislators.
And who are the key legislators that you're talking about? Is it a combination of, there's an aging committee, and then there's the public health committee. So where, are both those committees the ones that you?
So for federal purposes, obviously, our delegation is one that came out very early in support of some of the principles that we had around making sure that healthcare was affordable, especially to older residents, and that age tax for those 50 to 64 years was not implemented in Congress, and very vocal supporters of making sure guaranteed benefits in Medicare existed. But there's still always a challenge, because whenever there's a battle or a policy proposal, there are a number of ways to frame why that bill may be good or why it's not good. And where we look to our legislators, not only for their support on the bottom line, yes or no on a bill, but are you helping us tell the story and put a spotlight on the impact to older adults?
Right.
And we were pleased that during the February recess, when Senators Murphy and Blumenthal and our House delegation came back, and Representative Courtney out in the Eastern Connecticut, and they spotlighted and they showcased what it meant, what a 5 times as much cost means. Mm-hmm. Until you can quantify it and say, wow, someone who's 64 years old could potentially be paying, because of the age tax, $8,400 more for health insurance. That's unaffordable. That's going to be out of range. The other thing I think that's important, and John started to speak to it, is the compounding effect of healthcare. It is not, you can't dissect it and say, well, the Medicaid piece doesn't impact the private market and the private market doesn't impact the Medicare.
It all impacts each other.
And here's a great example.
Right.
If 50 to 64-year-olds are priced out of the market. They cannot afford to buy private health insurance because of the age tax or lack of subsidies, lack of access. That often will mean, just like family members I know, you push off the health care interventions
Correct.
and the preventive care that are low cost and can yield a good outcome.
And it costs more at the
And you
end.
keep pushing it, you keep pushing it until you get on Medicare. So now that means that Medicare is inheriting a much sicker population, a more acute population that has high demand needs. And that drains the Medicare piece of our healthcare system. So it really behooves us to make sure that people are getting the interventions they need early enough and they can have access to high quality healthcare at all throughout their life. Because if we just delay till they're 65, the Medicare pool is going to look a lot different. It's going to cost even more. So how those 50 to 64-year-olds can afford and access insurance actually really matters to the Medicare population too.
Right. Have you done anything about the cost of medications? And we can talk a minute about that. So I recently obtained a new client that was at New Britain General Hospital. So the social workers over there know us well. And when they end up with either indigent people or people that have no one to make a decision, they'll usually call us and ask if we'll be conservative person, which is normally me. 99% of the time it's someone that is critically ill and there's no one to make a decision on life support. And a recent one that I received was a 61-year-old who was a cardiac arrest and remained on a ventilator, and they need someone to make a decision for whether or not she should continue on life support. So they call us and I became conservator. I did end up getting someone who actually had funds, who's a retired teacher who never had any children. She is divorced. She's got a brother out in California. She ended up in the hospital for 42 days. So I became conservator person for her, and she's very complicated medical issues. So it was an ideal situation for us to take on as nurses. So in bringing her home, we were able to provide her home care. She had the ability to pay for that. And I then went in to get her prescriptions filled. So I wasn't sure she had Medicare Part D, which is what pays for medications, and then she's got coverage from being a retired teacher. So thought it was pretty good coverage. So I was able to make a copy of her card and bring that in. But two of her medications were over $300. And that was after they paid any medicine. So she has COPD, which is related to pulmonary issues. She was a smoker. And when I brought her to her doctor's appointment, one of the things the doctor discussed was that she was non-compliant with her medications. Well, I never really liked the term non-compliant. It sounds like someone's purposely not following directions, and the healthcare system and the people in it were really good about telling people what to do. We're not good in helping people do what they need to do. So as I started looking at the cost of her medications, even though she does have some funds to probably be home for a year or so, that's pretty prohibitive when she actually just turned 85 next week. When an 85-year-old goes in to get a prescription, and two of them would cost over $600 for a month. So how are you guys addressing
One
some
of the
of that?
One of the things that the strong front we put against the repeal of the Obamacare as proposed was saying it provided an awful lot of benefits for large drug companies. And it caused us to focus now in saying, maybe we want to be much more proactive about this.
Right.
And we're right now getting into saying we are going to launch an initiative to try to address the costs of drugs. One of the stats that I just saw says the average 65-year-old takes 4.5 prescription drugs a week. The average cost of those drugs is $25,000 to $26,000 a year, and of course these are not the exotic drugs or the new designer type things, which exceeds most people's Social Security
income,
Social
correct.
Security income. So if they had to pay them all out of pocket, and of course when you get into some of the increases in drugs in the past few years, the compounding is astronomical in terms of the increases. So as it's being developed now, I'm sure Claudio can add more, that AARP is going to be launching an initiative to try to combat the runaway costs of drugs.
'Cause it's,
And so when we talk about the healthcare system,
and that is a huge lobbying group, by the way, which we're all
Pharmaceutical.
aware, pharmaceutical.
Yeah.
Not only just on the state level, but having been involved in some Washington events.
Mm-hmm.
In Washington, it is a huge lobbying group of people out there.
yeah, from our perspective, though, it's also one of the major drivers of healthcare costs
absolutely.
in the
Huge.
country. And when you look at it, a couple of the statistics.
One of my husband's medications is $2,000 a month.
Wow.
And if he didn't have insurance to pay for that, it would be
and for our
ridiculous.
population, if someone takes a prescription drug, it's often for a chronic condition.
Correct.
So this high-cost drug is not just a 30-day and done.
Right.
It's every month after month where you're shelling out out-of-pocket costs to pay for it. The other concerning thing is it's not just the new drugs that are way outpricing the market or going for big increases. We're seeing, double-digit, 15.5% increases in 2015 when we have the last data from, showing that widely used brand name drugs that have been out on the market are increasing by that much. And even generics we're starting to see
Right.
priced up in the market.
And you wonder why.
Yeah, there's
You wonder why.
and so I think, we're exploring, looking at things like on the presidential campaign trail, both candidates had some ideas around prescription drugs. I know President Trump was one that basically said Medicare should negotiate for a better price.
Correct.
Private insurers negotiate.
Right.
And if you think about the pool of power that Medicare would have to drive down costs if they negotiated, it would be huge. And it could provide some savings there, delivering the same health care,
Right.
but just at a cheaper cost. That's a smart move. We should also look at safe reimportation and value-based pricing for medicine,
Right.
looking more at what's the value we're getting for a new drug therapy and putting pressure on pharmaceutical companies to justify those
And does
prices.
everybody need to be on a statin? I think that's one of the drugs that just boomed exponentially, for lack of a better term, in the last 10 years is the use of the cholesterol medications. Would it be better to get that person a little bit younger, get them to change their diet versus throwing them on a cholesterol medication?
Well, the good news is that it appears that there would be bipartisan support for a change in
Which is a good
getting
thing.
these prices under control.
Well, a half an hour goes by quickly, gentlemen. Claudio and John, thank you very much.
Thank you.
Again, this is AARP in Connecticut. We will post online for you access to them. I'm sure you're always looking for volunteers.
Absolutely.
My name is Sharon Gauthier. I'm from a company called Patient Advocate for You, and this is our monthly show called Senior Moments. Thank you very much for watching.